So you can include the students. The students are now online.
Yes. So I need to make myself the host so that I can.
Sure, no problem. So now we are going to start a very important topic, which is inflammation. So you have so that this important inflammatory topic you should understand, and you can stop me anytime, at least the whole class. I am not talking about online, but at least you people can stop me anytime if you are not able to understand. Put it there so that I can use my to move. Yes. Good. So can we? Okay. So inflammation. Shall we start now? Huh? Okay. So inflammation. What do you mean by inflammation? It's a defensive mechanism of a body. It's a first line of defense of a human body, or we can say it's a natural immunity in a way. So it's from the nature, and thanks to Almighty God that He has given us a best defense system. And as a human being, many of the organism, probably it is coming in our body and going out, we don't know, because our defense mechanism is so strong that the defense mechanism itself overcome a small infections which is taking place. So it is our good defense which is doing this inflammatory process. Now, basically, yes. So definitely we try to help the patient, but basically it's a nature which is healing the things. The doctor is trying to do that. Physician is just assisting, but basically it's a nature who is actually healing the things. So the definition of inflammation is very important, and this is a typical definition of inflammation which you must remember. It's a response of a vascularized, means inflammation cannot occur in amoeba, right, or unicellular organism because they don't have vessels. So it's a response of a vascularized tissue to the infection and tissue damage that brings cells and a molecule of the host defense from the circulation to the site where they are needed to eliminate the offending agent. Means in blood vessels, we have RBCs, WBCs, which is circulating continuously. We need those cells, which is WBCs, to come out from the vessel, go to the site where the infection is taking place and kill that infection. Okay? Okay, so this chart shows that these cells are taking part in inflammation. For example, the microbes, they comes in the body, then these cells, they are called antigen presenting cells. Most importantly, this macrophage and dendritic cells. Sometimes mast cells also do that, but mostly these two. These macrophages and mast cells, they engulf or take that bacteria and then they present that bacteria to to basically, if you go to through, because Dr. Garvin is going to take your immunology lectures, basically they present that thing to lymphocytes, the first cells. But along with that, they also, because they have a property, this macrophage, that they secretes some of the chemical mediators like amines and cytokines. Now, this initial chemical mediator, they start doing their action on blood vessels. And you know that in blood vessels, you have RBCs, WBCs, neutrophils, lymphocyte, monocytes, eosinophils to come out from the vessel into the interstitial tissue where they come and kill the organism, right? So this is a main process of inflammation which take place here, right? Okay, so in a way we can say that inflammation means inflame means hot or set a fire. So whenever you see inflammation, if you put your hand there, it will be little warmer, hotter, right? So means inflammation means inflame, hot, number one. And inflammation is a dynamic response of vascularized tissue, as we already discussed. So you had to have a vessels there. Then it's a protective response. Nature has give you a protection against the injurious agent, whatever it is, against the. So it serves to bring defense or healing mechanism at the site of injury where that has been lodged. So the bacteria which has entered into your body, now you need to have those cells which are inside the blood vessel to come out and kill that particular bacteria. Remember, in medicine, more than 60% of your treatment depend on inflammation. It's more than 60%. When you will become doctor, open your own clinic, more than 60% of your treatment will be regarding this inflammatory process. So you have to be very clear and you have to understand this process very clearly, that when you open your own clinic, more than 60% of the thing will be in your hand. Okay. Okay. It is classified according to time course. Either it will be acute or chronic. If you talk about acute means rapid, within minutes to 1 or 2 or 3 days maximum. And if you talk about chronic, it is delayed one, right? So acute inflammation, initial one, often transient, and they limit only for few minutes to 2 to 3 days. And the most important cells in acute inflammation are neutrophils. Now, chronic inflammation, on the other hand, it's subsequent inflammation, which actually follows acute inflammation. But sometimes it directly jumps as a chronic inflammation. For example, some viruses or some bacteria like mycobacterium, it does not go through the acute inflammatory phase. They directly jump into chronic inflammation, right? But majority of the time, the inflammation start as an acute inflammation, and if the injurious agent, the bacteria, is more stronger, then and it's not be controlled by this acute inflammatory phase, it then changes into a chronic one, which is a delayed one. It starts from 2 to 3 days, ends by weeks, months, and even years. There are some chronic inflammatory disease which usually take years to be completed. Do you have any example of that? Rheumatoid arthritis is a chronic inflammatory disease. It's an autoimmune one, but it takes years to heal that. You just give treatment, it subsides, comes again, so it goes on, and the things are like this. Okay. Now, acute inflammation, the reaction again, I'm just repeating again and again to make this thing born in your mind that it's a vascularized living tissue to local injury. It's a reaction of that vascularized. So for blood vessels, we have either change in the microcirculation. So a circulation is going on in blood vessel. So there had to be some changes in that, number one. Number two, therefore the formation of the fluid exudate, the fluid had to come out from the vessel into the interstitial tissue. And third one, you need the cells to come out. So making these three things together, we'll look into it, what's going on. So why inflammatory process goes on? What are the causes? It's not only the bacteria or viruses or fungi. There are many other things which can cause that inflammatory reactions. Starting with the microbes, definitely uh, pyogenic or non-pyogenic. What you know? What's the meaning of pyogenic? The bacteria which can cause pus is called pyogenic. So it could be pyogenic. And what are the pyogenic bacterias? You will probably learn later. Will Dr. Atif will tell you, like Staphylococcus or Streptococcus or Pseudomonas aeruginosa. These are pyogenic bacteria. When they comes in, they are so virulent, then they create a pus, mean extensive type of inflammation, mostly neutrophils, and they uh, gather together and form a pus. So bacteria, viruses, fungi, parasite, then other one physical agents like heat, cold, trauma, irradiation. While you are doing your ironing your clothes, sometimes you burn your hand. That is also one type of injury, and it is been cleared by inflammatory process, right? Or extensive cold, like of frostbite. If you go to some very cold areas and you keep your hand out, then you might have this frostbite, which is due to this cold. Trauma, irradiation, whatever. Chemicals like corrosives, acid, alkali, and toxins, they can cause this inflammatory process. Tissue necrosis like hypoxia and ischemia, which can cause this tissue injury. Then foreign body like blunt injury, uh, especially female, uh, they used to work in kitchen, and sometimes they cut their finger by knife. Or you can have your gunshot wound sometimes. That is also a way of causing inflammation. Then immune reaction. So hypersensitivity reaction can also evoke this inflammatory process. We will be discussing this hypersensitivity in your last part, in your second phase after midterm, and Dr. Gavan will be telling you how many hypersensitivity reactions we have. Okay, then they have a specific cardinal sign of inflammation. Remember, these cardinal signs you will only see in acute inflammation, not in chronic one. Cardinal sign of inflammation you will only see in acute inflammation. Okay, what are those? Number one, rubor. Rubor means redness. So the place where inflammation is taking place, that area will be red. Number two, warm, hot, calor. So rubor, calor, it is all, both of them is because of hyperemia, increase blood at that area, which is causing that area red and warm. The third thing is dolor, means pain. You will feel pain in that particular area. Pain. Number four is tumor, swelling, because excessive amount of fluid coming from the blood vessel into the interstitial tissue. So the whole area become edematous. So swelling. Number four, tumor. This thing, all these four signs, which was discussed about 20 AD by Celsus. Celsus is supposed to be a father of medicine. So it's not new. Inflammatory process is not new. It has been discussed 2000 years ago also, right? And finally, the fifth cardinal sign, which is loss of function or functionalisa, which was actually introduced by Virchow in 1870. So now, if we talk about the signs of cardinal signs, we also take functionalisa or loss of function is one of the signs of inflammation. So if I ask how many signs of cardinal sign of inflammation, so there are five, five, right? So you don't have to take out this one. Now, in 1927, Louis has given a triple response. He has added one more thing, and that is flush, flare, and V. So he said that at the area of inflammation, you had to have flush, which is dilation of the capillaries, flare, arteriolar dilatation, or wheal, means exudation at that area. So how will you see that? If you have a blunt pencil and if you rub that pencil on your skin, you will see after 5 to 10 minutes, skin is raised at that particular area. That is actually this triple response. Okay. Now, as we were discussing in the first lecture, there is suffix of it. If you see itis at the end, definitely you will be able to understand that we are talking about inflammation. Appendix, appendicitis. Stomach, gastritis. Colon, colitis. Liver, hepatitis. Bone, osteomyelitis. Joint, arthritis. Kidney, nephritis. So this is how, so on will go on. Whenever you're talking about inflammatory process, you will use the word itis. Okay. Now this picture shows you all the other tissues or cells are taking part in inflammatory process. Starting from the interstitial tissue, you see mast cells, fibroblast, macrophage, then you see these blood vessels. And in blood vessel, these cells which are inside, neutrophils, lymphocyte, platelets, monocyte, eosinophil, basophil, then they are proteins. Then this endothelial cells, basement membrane, this smooth muscles, and outside that you can see these elastic fiber, collagen fiber, proteoglycan. They all take part in inflammatory process. Yes.
Sorry for cutting you, but the people online cannot see the point. They only see the mouth. They didn't say anything. No comment.
Can you please check it? Can they see me?
Yes, they can see me.
Uh,
Oh wait, oh you mean no? The video recording is not on.
on this thing.
Okay. You can use this if you want.
Okay.
I don't know if it'll work with that.
Okay. So they want this mouse to be shown to them, right? But they can see the PowerPoint, right? Okay. Okay. So I'll. Where is this? This one. Okay. So now they can see me, huh? So these cells, which are outside the blood vessels uh, and plus inside the blood vessels, they all take part in inflammatory process, right? And we will be discussing one by one, not in this lecture, but in other lectures also. Today, it's a lecture of acute inflammation, so we will be discussing only neutrophils because neutrophil is a cell for acute inflammation. Yes. Okay, so this is another picture in which you can say this is appendix, and this shows all the cardinal side of inflammation. It is red, it is swollen, it is hot probably if you touch it, and means all the cardinal sign will be here. You can see it, and you can the patient is in intense pain when the patient had acute appendicitis. So there are signs of acute appendicitis which I'm not going to discuss it now. That is a separate topic. So in acute inflammation, it's a rapid host response that serves to deliver leukocyte and plasma proteins such as antibodies to the site of inflammation, as we were discussing. So by doing so, they had to have three major components. One is alteration in the vascular caliber. So the blood vessel should be little bigger in size. So the caliber will be changed, number one. Number two, structural changes in the microvasculature. Sometimes something which is should go on to push the cells from inside of the blood vessel to go outside. And finally, immigration of leukocyte from microcirculation to the interstitial tissue. So we had to learn three important things, right? So we'll do one by one. Before doing that, we should learn what is exudate and what is transudate. Exudation means the fluid or protein and the blood cells from the vascular system into the interstitial tissue. So when these cells are coming from the vessels into the interstitial tissue, this term is called exudation. But what is exudate? What is transudate? So the process is exudation, but we have divided into two main groups. One is exudate, and exudate is an extra vascular fluid that has a high protein, means excessive amount of protein is coming out, which is more than 3 grams per dl. 3 grams. If it is more than 3 grams, you will call it exudate. Along with this, you have Cellular debris means cells are also coming out, plus the specific gravity is more than 1.020. Although it's not mentioned here, you can write it that the specific gravity will be 1.020. It could be 1.025, it could be 1.030, but the specific gravity will be high. So the presence imply an increase in the normal permeability. So you need to have a increased permeability to let these cells, which are in the blood vessel, to come out. Okay, at the part of that injured area. Apart from transudate, they have a low protein content, which is less than 3 gram per dl, and mostly they are albumin, but they might have some cells, or there could be no cells, only fluid. The specific gravity will be low, means 1.010, less than 1.010. So we call this thing as transudate. Usually transudate occurs due to the hydrostatic pressure, increase in the hydrostatic pressure, or decrease in the oncotic pressure or osmotic pressure. Because of these two things, I'll show you how it acts, right? So transudate usually because of the increased hydrostatic pressure or decreased oncotic pressure, osmotic pressure, the fluid cannot come back into the vessels, so they form an edema outside. Okay. So if you see this one, the first upper one, this is a normal blood vessel flow. And if you see here, this one, hydrostatic pressure, this one, if you see, there is increased hydrostatic pressure in the arteriolar end. I'm talking about the normal blood flow. So at the arterial end, because of the increased hydrostatic pressure, the fluid goes out from the vessel, right? And then it nourishes this tissue. And then at the venular end, because of the high osmotic pressure, the fluid comes back into the blood vessel. So the fluid is going out, not the cells. It nourishes the surrounding tissue and it comes back into the vessel. Normal circulation, right? About 90% of the fluid comes back into the vessel. What about 10%? You have lymphatic system. So the remaining 10% or 5% which are left behind, they are taken up by lymphatics, and then from one lymphatics to the lymph node, so other channel, and they finally go into the thoracic duct and into the veins. This is how the things are going normally. What happened then? In We'll discuss first in transudate. As we said, either there is increased hydrostatic pressure or there is decrease in osmotic pressure. For example, in venous outlet obstruction, or there is congestive heart failure, what will happen? There will be increase in hydrostatic pressure. So the fluid will go on. For example, I'm just giving an example. For example, only 1 cc of the blood is going out, and then 1 cc is coming back. But in increased hydrostatic pressure, probably 2 or 3 cc of blood is going on, but at the venular end, only 1 cc is coming back, because you have estimated osmotic pressure. Remaining 2 cc is in the interstitial tissue, right? On the other hand, if the hydrostatic pressure is normal, but at the venular end, because of the low protein, because of some liver disease or some kidney disease where the protein is going on through the urine, osmotic pressure is less. So less amount will be taken. For example, 1 cc is going out, only 0.5 is coming back. So remaining 0.5 will be out. So slowly and gradually, they'll be pulling off the fluid outside the vessel in the intestine. That will cause edema. And that this edema will be increasing, and this edema will not be having the cells. They'll be having only fluid. Cells mean they don't have neutrophils or lymphocytes. Yes, 1 or 2, it's okay, but not majority of that. It's normal. This is transudate. What happens in exudate? In exudate, you had to have the protein leakage from the blood vessel. For this, there should be increased permeability. And this increased permeability you have with all the chemical mediator which actually cause the space produced between the endothelial cells, and then the cells can go out. So the larger protein, in transudate you have only albumin which is going out. In exudate you can have even albumin, globulin, even fibrinogen can come out. And all these cells like neutrophil, monocyte, lymphocyte can go out and take part in inflammatory process. So they are two different things. Is it clear now? Or you want me to explain again? Clear? Okay. So this is normal which we are talking about. Then we will take one by one. Now, the cellular exudate, the key player in acute inflammation is neutrophils. So, the neutrophils, they are produced in bone marrow, normally present in blood. How much? Yes, almost 55 to 65% or 70% in blood inside the vessel, right? Percent. They are short-lived, from 6 hours to probably 1 or 2 days, not more. They are specialized for defense roles, so they are ready to go out anytime because they are the number one high quantity cells in blood vessels. These cells are the first line of defense to go out and kill the bacteria, okay, or whatever the inflammatory process going on first. They phagocytose, or for example, it's bacteria which has entered, so they go out, engulf the bacteria, kill it, and then by killing the bacteria, they kill themselves also. So by doing so, they also causes some injury in the site where they have killed the bacteria. Now it's a process of macrophages. Now they come at the site, they clean everything, and then they take the dead debris from that area. And you feel nothing. For example, if you have slight burn at the hand, you will see in 2 3 days it goes off, without knowing that the inflammatory process has actually came there. Neutrophils came there, macrophages came there, they cleared everything, and they go back. Right? This is the natural process which is going on. And finally, capable of killing of the microorganisms. Now again, this slide, this shows that this is actually a normal one. Normally, if you see, this is arterial end, this is a venular end. There are few cells which is outside the interstitium, which is mostly lymphocyte and macrophages. As I said, macrophages are always there. These are the first cells which take up the bacteria, which is antigen presenting cell. So they present that cells to the nearby lymphocyte, see what is this. And then lymphocyte has a memory lymphocytes. We will be discussing this thing in immunity. We are not going to discuss this. And then they start the whole cascade of inflammation. The whole cascade, because then macrophage and lymphocyte, they go together and they secrete different chemical mediators, and they help in uh, gathering more and more cells at the site of inflammation. So in the other slide, which is B1, this one, this is actually, you can see that most of the cells are came out from the vessel into the interstitial tissue, and the things are going on now. So there will be vasodilatation, exudation of the edema, immigration of the cells from the vessels into the interstitial tissue. There should be some chemotaxis. Chemotaxis means that bacteria which attract these cells towards itself. Chemotaxis, and finally they kill it. Now this is another slide which shows that at this side, uh, that pointer is gone, Joanna. So, or I think it's okay. They'll be able to see this arrow. So this is actually a normal looking blood vessels thickness. So, and probably here is the organism which is lying, right? So what happens in inflammation? There will be change in the caliber. So suddenly there is a widening of the vessel, right? So before it was going as an axial flow. In axial flow, what happens? That the bigger cells, the bigger cell in blood vessel are WBCs, means neutrophil, lymphocyte, monocytes, eosinophils. They actually travel in the center. Then comes the RBCs. So after WBCs comes RBCs, and after RBCs then platelets, because they are even smaller. And after platelets comes the proteins, whatever's fluid is there. So by this, the the flow of the blood become easily been done. But what happened here? Suddenly, if you increase the size of the vessel, there will be turbulence. So in turbulence, what will happen, that the cells which are in an axial flow will not be in an axial flow now. Now the first thing we'll do, the RBC, they come together and form a rouleau formation. What do you mean by rouleau formation? They stick together and form a bigger cell, even bigger than WBCs. So by doing this rouleau formation, they push that WBC in the corner. So the WBC will go towards the vessel wall, right? So, and then the cascade will go on, which I'll be telling you later on. So what will it will do? It will change the vascular flow of the caliber, and the caliber, number one, increase vascular permeability. And the third one is definitely response of the lymph vessels, because excessive amount of fluid is going out along with the cells. Now, the change in the vascular caliber and flow, as I said, there will be dilatation, or this is the earliest manifestation you have. There will be dilatation of the blood vessels. And before dilatation, there will be transient vasoconstriction. So once the chemical mediator struck the blood vessel wall, it will constrict itself for 1 or 2 seconds and then dilate, right? So it will change the whole caliber and the axial flow. Okay, then what happens? The dilatation or dilation first involve the arterioles and then leads to opening of the small capillaries. What happens normally, that the whole capillary channels which are in the body is not open. Usually it is closed. Only few capillaries are open. But if you need something more at that area, then the channels opens and the whole capillaries become engorged with the blood. And that is a reason of hyperemia, redness and warmth, erythema. So vasodilation is induced by action of several mediators like histamine and nitric oxide. So these are the two important chemical mediators which comes first there by doing it. So if you see here, as I was telling you, that normally this is upper one is a normal one, in which you see that only this vessel, which is normal, is going on. These channels are closed. So the capillaries around it, normally it is closed, it's not open. But as you need inflammatory process, there will be engorgement of the blood vessel, thickness or increase in the caliber. By doing this, they have opened the channel of the capillaries. Now these capillaries are flooded with blood. Now you have ample amount to take out more and more fluid and cells from the blood vessels. Okay. Now you know this thing. I have already explained that's a normal one. The bigger cells flow in the center and the smaller one on the periphery. And in the inflammatory process, then the proteins and fluids are going on out. Now, vascular permeability. There is increased permeability leading to escape of the protein-rich exudate into the extravascular space. We need this thing. We need the cells, the fluid and cells to go out from the blood vessels at the site of inflammation. Okay, so there is a contraction of endothelial cells. Now, inside the blood vessel, the endothelials are joined together like this. There is no gap between it, right? But in the inflammatory process, with the help of histamine, bradykinin, and leukotrienes, the endothelial, they contract and there will be gap between the two endothelial cells. This gap is enough for the cells to go and escape from the blood vessels. Okay, number one. And this usually a short-lived one, lasts for only 15 to 30 minutes. This is immediate transient response. Remember my first picture in which the macrophages were engulfing the bacteria and the chemical mediators being secreted, and they are acting on blood vessel. So this is the first response they get, that there will be increased permeability. Number two, mild injury like X radiation, burn, or ultraviolet rays, they also cause damage to the endothelial cells. They also cause contraction of the endothelial cell, which it's a delayed response, start after 2 hours, but it can remain there for 12 hours or even day or two, right? It has a delayed response. So the delayed prolonged leakage may be caused by contraction of endothelial cells and also mild damage to the endothelial cells. So the things are going out now. The endothelial injury result in endothelial cell necrosis and detachment, number one. Number two, the neutrophils which are coming down and attaching to the endothelial cells, they also causes damage to the endothelium. I'll show you the picture and everything will be clear. And last one is the transcytosis, in which the endothelial itself make a hole and the fluid can pass through those endothelium. So if you see this picture, it will be clearer now that it's a normal flow, and in which you see that the larger leukocytes are flowing in the center. Then finally what happens, inflammatory process has started, and then there is a gap which has been produced between the endothelial cells, and the cells can go down, right? And then there will be some X-radiation or burn or irradiation can cause damage to the endothelial cells, and they can also cause the contraction of it, which causes even more permeability. Plus, when the neutrophils they are get attached to the endothelial cells, they also cause damage to the endothelial cells, so more and more fluid can go out. And finally, transcytosis, in which VEGF plays a role and make a hole between the cytoplasm of the endothelial cells, and the fluid can go transfer from the endothelial to the extravascular space. Okay. Now, lymphatics here, it plays a very important role, that as I said, that the fluid which are in the interstitial tissue, the lymph vessels, and the fluid takes the fluid and then it travels it to the thoracic duct, right? But here in the inflammatory process, because large amount of fluid is going on, so you need to have more amount of lymphatic channels. So there is also proliferation of the lymphatic channels here, right? So what happens then, the permeability fluid, they are taken up by the macrophages, and then they enter into the lymphatics, and through the lymph it goes into the lymph node. So if it is inflamed, so what happens, the lymphatics can also be infected. So if lymphatics is infected, they are called lymphangitis. And if it goes to the lymph node, the inflammation of lymph node is called lymphadenitis. So both of them will be uh, uh, inflamed. Finally, what happens, that this inflamed lymph node will do hyperplasia, means they proliferate. The lymphoid follicle will be proliferating more, and the lymph node will be more engorged and enlarged. Remember, when you are young, not now, young, you might be having some tonsillitis in a younger age when you were children. And doctors usually ask you to open your mouth and then put a light inside, and then the doctor palpates from your this area, which is cervical area. Why he was palpating this one? Hmm? Either he was looking at the tonsils here. No, the doctor actually was trying to see your lymph nodes, because the first lymph node after inflammation is cervical lymph nodes. So those who had tonsillitis, they have enlarged lymph nodes. By palpating lymph node, he then prescribe you some antibiotic to get rid of that acute tonsillitis, right? So these lymph nodes are really important, because the first line of defense from the tonsils, the lymphatics take the fluid to the nearby lymph nodes, and they are enlarged in size. Okay. Okay. Now, journey of the leukocyte, reaction of the leukocyte. What happens? The leukocyte from the vessels come out into the interstitial tissue, which is called extravasation, and can be divided into following steps. Number one is margination, rolling, and adhesion. So the neutrophils which are flowing in the center will go down and it marginates with the endothelial cells. It rolls upon and get stick to the endothelium, right? And then finally it comes out from the vessels. Then we have migration of the neutrophil from the blood vessel to outside, and finally towards the site of inflammation which they have to go. So this is another picture in which you can see that there is change in the axial flow. So if you see here, the neutrophils are in the center and then they are shifting towards the periphery. So this is called pavementing. Then there is rolling of these neutrophils, and then you have finally they have they stick towards the endothelium, and finally the process of diabetes starts, and the neutrophil by using their amoeboid action they leave these blood vessels and go out. Okay, this is how it does. Okay, so it comes down and from the middle, comes down, migration, rolling, adhesion, diabetes, chemotaxis, and phagocytosis. So by this, it engulfs the bacteria. How this process goes on? The chemotaxis is ability of the cell, such as neutrophil, to move along the concentration gradient towards the chemical substance. So the bacteria, which is outside the blood vessel, they give a signal, which is chemotaxis, and they ask neutrophils to come to that area. Now, what are chemotaxis substance? Number one is bacteria itself, which causes attraction to the neutrophils, which is exogenous. Or endogenous, we have inflammatory mediators like arachidonic acid metabolites and the leukotrienes. Then you have cytokines like interleukin 8. Then you have complement system like C5a, and then they have neutrophil degradation products itself. They attract neutrophil to that area, right? Please kindly stop me if you are not following it. I can make it, uh, I'll make you understand again, right? Okay, so what happens that there should be an addition of this neutrophil to the endothelial cells. So how it does? The increased leukocyte adhesion result from interaction paired between the leukocyte and endothelial cells. It has to be attacked together. So by doing so, we have integrins, selectins, immunoglobulin superfamily, and glycoprotein, which take parts in addition of these neutrophils. So, they have all inflammatory process. If you see this picture, it's very important that this is neutrophils. It has to come down, they roll, and then they go out. Doing this process, how it starts. Now, if you go down here, this is a macrophage. This is a macrophage, and it has taken up the bacteria because it's a first cell which eats up the bacteria, right? As it eats a bacteria, it secretes some of the chemical mediators like TNF and interleukin 1. Also, histamine and thrombin come down, right? So this histamine and thrombin, they cause this endothelium to become more active. How it has become active? There are P-selectin and E-selectin in endothelial cell which are non-active phase. So when this chemical mediator like histamine and thrombin, which goes and activate this endothelium, so the Weber pedal bodies which are present inside the endothelium become activated and goes on the top, on the surface, and act like P-selectin and E-selectin, right? Normally, you don't see these P-selectin and E-selectin in this endothelium. But as it has been activated by this chemical mediator, histamine and thrombin, they go up and they are activated now. Now they are waiting for the neutrophil to come down, right? Not only this tumor necrosis factor and interleukin 1, they also activate this endothelium, and they activate this integrin, which is ICAM and VCAM, intracellular adhesive molecule, uh, intercellular adhesive molecule, and vascular cell adhesive molecules. So these two are then activated, right? Now, this is exactly the same. On the neutrophil, if you see here, in neutrophil, what happens, this chemical meteor they do, they activate the silyl Lewis X modified glycoprotein. This is also called L-selectin, which is in the neutrophils, and integrin also. So they both things are activated. Although integrin is now in a low affinity state, the door are closed. If you see it carefully, that these integrin has a closed door, low infinity. What happens as the cell comes down? The silyl Lewis X modified glycoprotein, they are attached with P-selectin and E-selectin, right? So this E-selectin and P-selectin, it does not adhere it strongly. So they allow this neutrophil to roll upon the endothelium. So they help in rolling of the neutrophils on the endothelial cells. Now, what happens? That the same activated macrophages and neutrophil, they secrete chemokines. Now, this chemokine comes up and attached to this protoglycan. This protoglycan helps this chemokine to attach with the neutrophils, right? And this neutrophil, if you see here, this integrin, which is of low affinity, the door was closed. By this chemokine, the door becomes open and it becomes in high affinity. Now, this high affinity integrin, it attaches with this ICAM strongly. So here there is addition of neutrophil with the endothelial cells. Now, once it is tightly been captured by endothelial cell, now the process of diabetes is start. So ICAM, VCAM, and PCAM, all these three adhesive molecule, they actually grab this neutrophil and try to push it down, right? And you all know that the basement membrane here is very strong. So how it is coming out from this basement membrane? So neutrophil itself secretes some enzyme, collagenase enzyme. This collagenase enzyme, it destroys the basement membrane and the neutrophil now comes down, right? And if you see here, there is also integrin in this extracellular matrix. So it usually take it, the neutrophil down and pushes forward towards the chemotatic area where it has to go, where the microorganism is already present. Is it clear now? So these are the sequence of events which are going on. Means silyl X protein, which has been activated by these chemical mediators. Then the cells comes down. By the time this histamine and thrombin, they also cause activation of this Weber pedal bodies, which come on the top in the form of P-selectin and E-selectin. Right now, it's ready to grab the neutrophil. Now this tumor necrosis factor and interleukin 2, which activates this ICAM and VCAM, which is integrins of the endothelial cells. On the other side, this neutrophil itself, not only they have activated silyl X glycoprotein, plus also this integrin is also activated, but it is not in a high affinity state. It's in a low affinity state. What happens when it comes down and this proteoglycan, the chemokines which has been secreted by this inflammatory cells, they go up, attaches to the protoglycan, then they attach to the neutrophils, and the low affinity integrin become high affinity integrins, and it's open its store, and now it attaches to the ICAM and VCAM. So for example, this is endothelial cell and I am neutrophil. I will go and attach directly like this one, attach it one. Now the neutrophil has to go out. So ICAM and VCAM has done its job. The third thing is to push that neutrophil from the blood vessel out, and which is done by ICAM, VCAM, and PCAM. So it grab the neutrophil, make it down, but unfortunately we have, or fortunately we have basement membrane. It does not allow anything to go down. So they secrete collagenase enzyme, which destroy the basement membrane and let this neutrophil to come down. Clear? Then it goes to the area which has to go and it kills the bacteria. Good. Any question? Yes.
Why we have Veroni is that why don't the neutrophil directly go inside without,
Directly.
yeah, without Veroni? Why do you think?
Actually, this is very important because basically the neutrophils were floating in the center, right? Now, because of the turbulence, the RBCs form rouleau formation, and they become in the center. They pushes this neutrophil to go apart. Now they had to have something to catch, right? So they start with the rolling process because it is very difficult to catch the neutrophil. So first you have some magnet to come in to tightly comes towards the endothelial cells, which is held by P-selectin and E-selectin. Finally, once they are near to that endothelial cell, although they are not adhere to it, they are still rolling. Then this integrin, they take part, and now they stick the neutrophils closely with the endothelial cells, and then they come out. Okay. Now, this is a chart which shows, which I have already mentioned in my whole description. So if you see the chart, it will be clear then. Okay. So I'm skipping this chart now. Now, what does neutrophil do? Movement from vessel to the point, adhesion to the microorganism. Now it engulfs that, phagocytose, and then killing of the microorganism. Now, killing, we have two different methods, either oxygen dependent or oxygen independent. So the important one is oxygen dependent one. Independent one we will discuss, but the important, because it's more than 100 times more powerful than this one. And then we have a lysosomal enzyme. What happens? The phagocytosis involve three sequential steps. One is recognition and attachment of the with the leukocyte, then engulfment, they engulf the bacteria, and finally it degrade or kill the bacteria. How it does? You see this picture, and in this picture you see that the microorganism is recognized by this receptor. Then it take the microorganism inside by a amoeboid type of movement. So it usually, for example, this is one microorganism, and then it engulf like coming the both podocytes, and it takes this microorganism inside the neutrophil, and then it comes as a phagosome. As it comes down inside, then we have a lysosome present in the neutrophils. So this phagosome will attach to the lysosome, and it opens. So the lysosomal enzyme, which are there to kill the bacteria, it goes in and then it kills the bacteria. Lysosomal enzymes. Clear? So this is actually oxygen independent type of killing of the bacteria. Now the other one. Now once the bacteria is in, right, it activates this phagocyte oxidase enzyme. This phagocyte, please kindly take see here, right? So this phagocyte oxidase, it converts NADPH into NADP. By doing so, this convert this oxygen into superoxide. Now this superoxide, with the help of MPO, myeloperoxidase, which secretes chlorine here, and by having chlorine here, it divides this hydrogen peroxide into uh, hypochlorite plus OH ion, hydroxyl ion. So hypochlorite and OH ion, they are the powerful killer of the bacteria. On the other hand, arginine, this gives nitrous oxide with the help of inducible nitrous oxide synthase enzyme. So once the nitrous oxide is in, this superoxide joins with the nitrous oxide and form peroxynitrite. This peroxynitrite is also strong killer of the bacteria. So by this, the bacteria is been killed. So if it is not killed by oxygen independent pathway, then oxygen dependent pathway take place, and finally it has been killed. So these powerful uh, chemicals which are there now, after killing bacteria, the neutrophil bursts itself, it dies off, and the chemicals are then secreted outside. These are so powerful that they injured the local area also. After inflammation or inflammatory process is over, then macrophages come there and they clean that area, and then they take the necrotic debris away from this area. So after 2 to 3 days, you will not find anything like this damaged area, injured area. Okay, yes.
less superoxide to explode the
Actually, you need the nitrous oxide is not present in that circle, right? So you had to have nitrous oxide from outside. So you get this nitrous oxide from this arginine. So this arginine, with the help of nitrous oxide synthase enzyme, it pushes this nitrous oxide inside here. So we have already superoxide present inside this circle. So this superoxide get attached with this nitrous oxide, and they causes peroxynitrate, which is strong killer. Okay. On the other hand, if you, for example, doesn't have this phagocyte oxidase enzyme, you will not have superoxide, right? So we will discuss the diseases later on. So what happens? We have to go back also. So some of the patient, they have recurrent infection all the time. Why? Either they have deficiency of leukocyte adhesive deficiency type 1. What happened here? They have a defect in the biosynthesis of beta 2 chain shared by the LFA1 and MAC1 integrins. So you know that in neutrophil, we have two things. One is silyl, right, modified one, silyl X modified, and other one is integrins. So if this beta chain is not, there is some defect in this beta chain, well, what will happen? The integrin will not be activated, right? So this neutrophil will be without integrin, although the rolling will be there, but tight adhesion of the neutrophil will not be there. So neutrophil may not come out at the site of infection, number one. Number two, this leukocyte adhesive defense type 2, deficiency of type 2. What is this deficiency? It's caused by absence of silyl X, Lewis X, the fucose containing ligand for E and P selectin. So what will happen? As a result of defect in fucosyl transferase enzyme. So these patients, they does not have fucosyl transferase enzyme to convert into silyl X protein. So if silyl X protein is not there, what will happen? It will go down, but it will not help in rolling process. It will not attach with E and P selectin. We can go back to that picture, this one. So in the first type, this integrin will not be there. So it will not attach with ICAM and VCAM. In the second type, this silyl Lewis X modified glycoprotein will not be there. So it will not help in doing this rolling process. So maybe the neutrophil not even come down, right? Now coming to the third one, and third one is inherited defect in phagolysosome function, means, which is Chidak-Higashi syndrome, in which uh, here you see that the organism are being taken as a phagosome, but this phagosome is not been combined with lysosome. When phagosome and lysosome are not combined, what will happen? The enzymatic killing will not be taking place. Although phagocyte has been done, but non oxygen independent type of killing will not take place, right? And the last one is inherited defects in a gene encode component of phagocyte oxidase, which generate superoxide, right? So if you go back here, this in this defect, there is a defect in the enzyme which does not activate this phagocyte oxidase. When phagocyte oxidase is not activated, what will happen? This superoxide will not be formed. When this superoxide will not be formed, it will not convert into hypochlorite or peroxynitrite or hydroxyl ion. So the oxygen dependent intercellular killing will be gone. So please kindly remember these four important defect of inflammation, right? They can be asked in your exam. Finally, what we have, either there will be complete resolution after inflammation, taking 1 or 2 days. After this, there will be complete resolution. Nothing is going on. Nothing, no problem is there, right? Or healing by connective tissue, means there is some more inflammatory process. The organism were little stronger. So instead of 1 to 2 days, it has taken 4 to 5 days, 6 days. Finally, when it becomes okay, there is some fibrous tissue proliferation goes on. So there will be repair by fibrosis. And number three is it will convert into chronic inflammation. Neutrophils say that no, the organism is more tough. I cannot handle this situation. Now comes this lymphocyte and macrophage, take this thing and take care of it. I am not responsible. So this whole acute inflammatory change will come into chronic inflammation. So in this picture, it will be clear that in first stage, the injury, this acute inflammatory process goes on, and then it's complete resolution. You see, nothing is here without any functional defect. In the second process, this acute inflammation by some healing process repaired as a fibrosis. So in this fibrosis, there is some defect in function. Remember, in chronic infection, there is some defect in a functional process. It will not 100% as it was before. Or this acute inflammation will go into pyogenic inflammation. If the organism is more virulent, more and more neutrophil and pus is formed, and finally it will heal by this fibrosis method. Or finally, acute inflammation will change into chronic inflammation. Neutrophil will say that I'm sorry, I'm not going to kill this bacteria, lymphocyte and macrophage, please come and help me. And this acute inflammation will change into a chronic inflammation. And this chronic inflammation then it's always been repaired as a process of fibrosis, right? But along with this, having said that, there are few injuries which does not take acute inflammatory pathway, like viral infection or some chronic infection, persistent infection, or autoimmune disease. They don't go the pathway of acute inflammation first and then come into the chronic inflammation. They start itself as a chronic inflammation, and then it is always been repaired as fibrosis. So this is all about acute inflammation. This picture shows you all the cardinal signs of inflammation. You can see this is heat, this is redness, this is swelling, this is pain, and this is loss of function, right? So any question regarding inflammation, please, I'm there. Any question from the online students? You can send your question to the TA and she can tell me if there is any question. No? One question. There is one question from online. No, actually interleukin 1 and tumor necrosis factor, they activate not the integrins. This tumor necrosis factor and interleukin 1, they actually activate integrin, not P and E selectin. P and E selectin are being activated by histamine and thrombin, right? So this is one question. Yes. What is the other one? Okay. Any question from the class?
B and E are the endothelium, right?
Yes. P and E,
Yeah.
they are endothelium. L is leukocyte. Okay. L is leukocyte. P and E is endothelium. P is also some of the what you call platelets. That's why it's called P. But the same one is also for endothelium. Anything else? Nothing? Is it clearly understood? Are you happy? Next time we'll be dealing with chemical mediators. That is also a very important topic, chemical mediators, because without chemical mediators, you cannot have inflammatory process. So we will touch each and every chemical mediators, which is important one. Please kindly attend that. Thank you very much. Can I have that USB?